Type B dissection is nowadays treated with stent grafts, and they essentially lead to thrombosis of the false lumen, and over a period of time, expansion of the true lumen and shrinkage of the false lumen. And here's an example of how this happens over a period of time, leading to optimal result. In the last year, there was a position statement about how do you manage type B aortic dissection, and the treatment of choice for a complicated acute type B dissection is endovascular. And by the term complicated, one means persisting or recurrent pain, uncontrolled hypertension despite full medication, early aortic expansion, malperfusion, and signs of rupture such as hemothorax, increasing periaortic or mediastinal hematoma. Whereas in uncomplicated, primary conservative approach with close surveillance may be justified until complications arise. So there's no doubt that if you have a complicated type B, you need to do something. And what are these complications due to, these malperfusions? They are basically due to intimal flaps, and this has been classified in this paper. And there's these type 1 flaps where there's a flap in the aorta alone, which could be perpendicular or parallel to the side branch, which could obstruct or not obstruct the side branch. And then there's the type 2, where the flap extends into the visceral artery, and here again, it could or could not obstruct the artery concerned. And then there's type 3, where there's a complete avulsion of the flap from the side branch, and here again, there could be an obstruction to the flow into the side branch, like type 3C, where the intimal flap in the artery induces a stenosis. So whichever way the obstruction of the side branch occurs, we need to do something about it. And there have been a number of reports on this. Here's an example from the literature showing obstructed right common iliac artery, and it has been the flap, the intimal flap was recanalized and ballooned, resulting in a good flow down the right lower limb. People have tried to be more precise about how you recanalize through the flap, and one article that came out in 2003 used a probe in the inferior vena cava to guide a Brockenbrough needle to puncture the flap from true lumen to false lumen. And the middle panel shows the needle as labeled as number 1, and the right panel shows flow through the fenestration that's been made in the flap. Here's another technique where there is a tearing technique used. In this particular case, there was inadequate communication between true and false lumen, and so using a radio frequency guide wire, a fenestration was made, and then a wire was passed through which was caught with a snare on the other side, and then this wire loop was pulled down, and as the wire came down, it kind of sliced through the intimal flap, producing a long linear fenestration in the segment that the wire pulled through, and this was the result that was obtained with a follow-up CT angiogram on the right side. There's another way of fenestrating, and here you can kind of scissor your way up. This was described by Beregi, and basically 2 stiff wires are passed on either side of the intimal flap, one in the true, one in the false, and both these wires pass through the same sheath, usually an 8-French sheath. We use an arrow sheath, and then when you move the sheath up, you cut through anything that's between the wires, and that way you can produce a long linear fenestration from below. But what may happen is if the intimal material is very resistant, you may not be able to cut through, so it's not necessarily successful always. So I'll show 2 illustrative cases. A 56-year-old female, hypertensive, came with sudden onset back pain 3 months back with flaccid quadriparesis within 10 minutes of the onset of pain. BP was 230, 130 at that time. Fortunately for her, much of this weakness improved, and she came to us with just a right lower limb monoparesis. angiogram showed a type B dissection with very little communication between true and false. And from the true lumen, the superior mesenteric artery and the left renal artery were seen to arise, whereas the common iliac and right renal artery came off the false lumen. So we were worried that once we close off the entry point, we wouldn't have flow into the branches from the false lumen. And so we used a coronary wire to cross from the true to the false lumen, and then we ballooned that penetration point with a 16 mm balloon. And then we passed a catheter into the false lumen, and then we found that we can see the celiac and the right renal artery now. But still the communication between true and false was not good enough. So then we used Berege's technique. You can see the scissor going up and slicing through that. But even this was not very successful. So we then went from false to true a little higher up with a stiff end of the coronary wire. That's the confirmatory angiogram on the right showing the false to true passage. And then this was also balloon dilated. And then we deployed a stent graft and sealed off the entry point with a chimney graft for the left subclavian artery, and we got this final result. And the lower down, you can see there's good communication between true and false. Now, in this case, we have not extended the graft down to the celiac because of financial reasons, but ideally we would cover all the way to the celiac artery to get more thrombosis of the false lumen. Here's another case, 40-year-old male, hypertensive, acute onset chest pain, right lower limb weakness. This was his presentation, no flow down the right iliac artery. So we went from the left iliac to the right iliac, deployed a stent there and got this good flow down the artery on the right side. That improved his right lower limb weakness. And then that was on the 21st of March last year. And then 8 days later, we did the definitive procedure. We had a sheath in from the left subclavian, and we had a fenestrated graft with a single fenestration for the left subclavian artery. That's the fenestration being cannulated, and that's the fenestration being, the covered stent being deployed in the fenestration, and that was the result. But in this case, we found that there is a true-false communication further down the left subclavian through which there was an endoleak into the false lumen. So we had to go back and put in some coils to close off that endoleak. And after that, we got a good long-term result. You can see the coils there in that false lumen, the patent fenestration, covered stent in the fenestration, no opacification of the false lumen. And another 3 months later, a CT angiogram. So there have been many series that have looked at the results of these procedures. Here's one from Berege in 2003. Just skip through it, but the main message here is that even with all this, there is a significant amount of morbidity in these patients. And this is another one that came out in 2009, 69 patients treated with fenestration and or stenting. Those are the morbidities that occurred. And this is the survival. So this is not a benign condition when you have a complicated type B dissection, and freedom from open repair or aortic rupture was only about 40%, 60% at about 10 years. And this is a very recent study, 2 years ago, which looked at 85 patients with complicated type B. They have listed out the various kinds of adverse events that occur either early or late. And the important point is right at the bottom. The estimate mortality is 10.8% at 30 days and 29% at 1 year in this group of complicated type B aortic dissection, which is treated by contemporary techniques. Thank you.